Live now, ma'am. Good evening, esteemed faculty members
Yes,
and
sir.
all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Endometriosis, organized by Pinnacle News Series, association with Jabalpur, Varda, Ujjain, and Bellary OBGYN societies. So it's my privilege to introduce the MOC of today's webinar, Dr. Madhumita Arun Kartik ma'am. Ma'am is the treasurer of Salem chapter of Tapisar and also consultant of obstetrics, gynecology, and reproductive medicine in Salem. I welcome you,
Thank you,
ma'am.
Sahiti. Thank you so much, Sahiti. I'll take over. Yeah. So it's my pleasure and privilege to introduce one and all to this very unique webinar series, that is a Pinnacle News series, which is convened and coordinated and brought to us by Professor Sampath Kumari ma'am. This webinar plays is very unique in a way that it brings all the four corners of our country together. So it is my privilege to be the MOC for today. So we'll move on to the so to introduce now for the prayer song.
Yes, Sahiti.
Just a second, ma'am. Small technical issue.
Okay.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय
Thank you. So it is my pleasure to introduce Professor Dr. Sampath Kumari ma'am. Ma'am is a professor and HOD of obstetrics and gynecology at Sri Muthukumaran Medical College and Hospital and Research Institute. She was the Foxy Vice President in 2022. Senate member of Tamil Nadu Dr. MGR Medical University, National Corresponding Editor of Jogi, Founder Secretary of Tamil Nadu Federation of Obstetrics and Gynecologists. She is the current President of OXY, and she's also the retired Deputy Director of IOG. And she's also the President of Board of Studies of Tamil Nadu Dr. MGR Medical University. And she received the first ICOG Distinguished General Council Member Award. And also she's received the IMA National President's Award and the Tamil Nadu State IMA State Branch Award in 2021. Yes, ma'am.
Thank you, Dr. Madhumita. I welcome you all for this webinar on endometriosis. This is the Pinnacle News series with the idea of having societies from North, East, West, and South. Today we have Varda, Ballari, and Ujjain and Jabalpur societies. This is our 13th series. Every month and second Thursday and fourth Thursday, we are conducting this webinar. Second Thursday being obstetric topic and fourth Thursday being the gynec topic. I welcome all the Varda President, Dr. Poonam, and Dr. Secretary, Dr. Shilpa, and the Bellary President, Dr. Jyoti, and Secretary, Dr. Anupama, Ujjain President, Dr. Neelam, and Secretary, Dr. Archana, Jabalpur President, Dr. Raki, and Secretary, Dr. Komal. We have the chief guest being Dr. Poonam and guest of honor being Dr. Raki and Dr. Neelam. We have the two sessions. The first session being the endometriosis adolescent. The endometriosis now the incidence is increasing drastically. So we have the adolescent endometriosis. Always it is better to identify it in the adolescent itself. We have the speaker being Dr. Deepthi and chairing session by the Dr. Komal. And we have different case scenarios of endometriosis. So the panel being moderated by Dr. Ranu and Dr. Kirti, and expert being Dr. Ramaraju. And we have the wonderful panelists, Dr. Ashita, Dr. Sudha, Dr. Shruti, and Dr. Meghna. And I welcome my MOCs, Dr. Madhumita, always sweet and smiley, and Dr. Radhika Gauri, always obeys our queries. So I welcome you all for this webinar, and I think you will have the wonderful scientific session. Back to Madhumita. Whenever the chief guest joins, we can get the blessings from the chief guest and guest of honor, Madhumita. Thank you.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Thank you so much, ma'am. So proceeding on to the scientific session. We have a chairperson, Dr. Komal Jain, who's currently working as a director and consultant at KJ Memorial Hospital at Jabalpur. She is also currently the secretary of Jabalpur Obstetric and Gynecological Society, and she was a past treasurer of Jabalpur Obstetric and Gynecological Society. And her special areas of interest is high risk pregnancy, diabetes in pregnancy, and infertility. Komal ma'am. Komal ma'am, are you there, ma'am?
I think Komal is here.
Yes, ma'am. Komal ma'am has joined.
Hello, good evening
yes,
all.
Good evening, ma'am.
Good evening.
Yes, ma'am. Welcome you to this webinar, ma'am. Can you introduce Deepthi ma'am, please?
Yeah, Dr. Deepthi Gupta. She's a very good friend of mine. Okay, affiliation. Dr. Deepthi Gupta is currently Associate Professor, Department of OBGY, NSCB Medical College. She's a consultant and unit head at Ankur Fertility Clinic and IVF Center, Jabalpur. She is the secretary of MPOX 2024-26, MCM, MP ISR, and MP SE Agoin, and West Zone Coordinator, Foxy Quiz Committee, NCE, and Peer Reviewer OG. She has got many awards. Foxy, MR, NA, Mr. NA Pandit, Mrs. Shelja Pandit Award 2024, ISR Dronacharya Award 2023, CS Dawn Prize AICOG 2022, second prize in Hindi essay by Foxy, PAC and IMS, first prize in poster by Foxy, Adolescents Health Committee 2020, second prize paper MS Con 2011. Publications about 15 indexed and 15 chapters. Dr. Deepthi.
Thank you so much, Komal. And you have actually been very instrumental in making this webinar work out. Sampath madam was so happy, Rakhi madam, and tumne matlab you provided the entire team, group of people, promptly everything done. And but my heartfelt gratitude to Sampath madam for giving me this opportunity to speak on a less discussed topic on this August platform. And I hope that all of us will start thinking more about it in this direction. So with everybody's permission, I would like to start sharing my screen, and so that we can move on with the academic discussion. I hope my screen is visible.
Yes, ma'am.
Yes, ma'am. It's seen, ma'am. Yes, full screen.
Perfect. So the topic that I'd be discussing is adolescent endometriosis. Adolescent endometriosis, endometriosis in itself is so important that it has found a place on the WHO fact sheet, and which states that endometriosis affects roughly 10% of reproductive age women and girls globally, though all of us know that actually prevalence depends on the subgroup of patients that we're talking about. It is far more when we talk about infertile women or women with chronic pelvic pain. It is a chronic disease associated with severe life impacting pain during periods, sexual intercourse, bowel movements, and or urination. This is a simple language used by WHO. There is currently no known cure for endometriosis, and treatment is largely suppressive or aimed at controlling symptoms. And access to early diagnosis and effective treatment is limited in many settings, especially in the low and middle income countries. Endometriosis, we know, is a public health disorder which affects a staggering 247 million women globally and as many as 42 million women in India. Just to give you a perspective, this figure is equal to the entire population of this country marked in green, Argentina. Endometriosis, we all know, is a estrogen-dependent condition, largely an inflammatory condition marked anatomically by the presence of extrauterine lesions containing both endometrial glands and stroma. So this is a beautiful, just a pictorial representation which tells us that genomic alterations along with epigenetic theory, invagination theory, lymphovascular dissemination, stem cell theory, retrograde menstruation, which is the most commonly accepted one, coelomic metaplasia, they all contribute to the initiation and establishment of endometriotic lesions. And as far as the clinical presentation is concerned, pain is one symptom which we mainly associate with endometriosis, especially excessive menstrual cramps, infertility or rather subfertility. Intermenstrual bleeding may be observed, painful urination and or defecation, abnormal or heavy menstrual flow, and because of that vicious cycle of pain and heavy bleeding, a lot of women may experience fatigue, pain during intercourse, especially deep-seated dyspareunia, and constipation. It is a progressive disease. Unfortunately, despite so many years of dealing with it, the natural history of endometriosis is still poorly understood. Another concept being discussed now is whether it is really a progressive disease or whether each lesion is a new lesion. As far as the prevalence is concerned, in adolescents, there was a small group of girls who underwent laparoscopy for chronic pelvic pain not responding to medical management. And in that group, as many as 47 to 70% of the girls had endometriosis. And we know that the disease diagnosis is usually delayed by an average of anywhere from 4 to 11 years. So clearly it means that when a girl or when a woman aged about 24, 25 years is coming to our clinic with dysmenorrhea or with infertility and we are suspecting endometriosis, then perhaps this disease had its roots somewhere in her adolescence. Also, one paper has reported that younger the woman is at onset of symptoms, usually the longer the period for diagnosis to be made, median delay being 12 years in women aged less than or equal to 19 years and 3.3 years in women aged more than or equal to 30 years. So definitely there is a multifactorial delay in diagnosis as well. And some of these causes are patient related and some are clinician related as well. Patient related, largely lack of awareness. PCOS is a very fancy disease which everybody talks about, but endometriosis, unfortunately, is not as much spoken about. Then symptom normalization. It is a very reflex response for almost every lady in the household or every clinician at the first instance that some amount of dysmenorrhea is normal and associated with ovulatory cycles and it is okay, etc., etc. Then socioeconomic status and of course access to healthcare. As far as clinician related factors are concerned, again symptom normalization, probably lack of expertise which we may be hesitant to accept, and then of course diagnostic challenges which make it a very, very huge bottleneck to diagnose endometriosis even when we have strong clinical suspicion. A few characteristic features of adolescent endometriosis. We know that some of the risk factors would be outflow tract obstruction. So it could be a non-obstructive Mullerian anomaly or an obstructive Mullerian anomaly, obstructive ones being more commonly associated with endometriotic lesions. Family history is very, very important, and early age at menarche also increases the risk. Some symptoms that we need to watch out for, atypical or acyclic pain being a very, very important one. Often this pain is resistant to the common first-line medicines like combined oral contraceptive pills and NSAIDs. We must not forget that endometriosis is the most common cause of secondary dysmenorrhea in an adolescent girl. And very often, this is a disruptive pain which disrupts their everyday life, be it their extracurricular activities, be it their school activities, school attendance. So it is a disruptive pain. This we need to pay attention to. And findings which may not be very reliable. If we are doing a recto-abdominal or a rectal examination, then we may be able to appreciate some nodularity. In an ultrasound, small endometrioma may be appreciated. And we must also get into the habit of looking for site-specific tenderness, which may be present in endometriosis, even in the absence of an obvious endometrioma. So once again, we need to watch out for acyclic or atypical pelvic pain, chronic pelvic pain, associated or coexisting symptoms like heavy menstrual bleeding, premenstrual spotting. Systemic symptoms like nausea and dizziness are strongly associated with presence of endometriosis, and associated bowel bladder symptoms like increased frequency of micturition, increased frequency of defecation, some pain or discomfort during defecation, constipation, especially if they have a cyclical pattern. Approximate frequency of symptoms which was reported by a paper, both cyclic and acyclic pain was the commonest, reported by 63% of the girls, followed by gastrointestinal pain by 34%, followed by acyclic pain only in 28%. Coming to the examination, in a girl we are suspecting adolescent endometriosis. The examination is aimed at two things. One, we are looking to rule out other pelvic pathologies. So it is extremely crucial that we rule out other pelvic pathologies which may be coexisting. She may have an obstructive Mullerian anomaly giving rise to hematometra, hematocolpos. There might be some simple ovarian cyst as well. Then, of course, a very important thing which we often neglect is shared decision making. Here, not just the consent, but the assent of this adolescent girl, because, these experiences of examination, genital handling, invasive investigations can have long-term implications on her reproductive life, her sexual life, etc. in future. We may have to consider an abdominopelvic examination, and there may be a need for rectal examination as well. However, most of the reviews rule out that we really do not need to do examination under anesthesia simply to confirm or diagnose endometriosis. Continuing with investigations, a baseline blood picture and ESR mainly to rule out pelvic infection. We must always rule out urinary tract infection because most of them are school going, using common toilets. CA-125, a very important point here is that it is not useful, and in all likelihood it is better avoided. Ultrasound has to be the first line of investigation, and we may consider a 3D ultrasound, especially if we have some positive findings on our routine 2D ultrasound. MRI definitely is not the first line investigation, but it does have a certain place in adolescence, because in this age group, superficial lesions are more common than the deep lesions. And we must always get both T1 and T2 weighted sequences done, because the T1 sequences pick actively bleeding lesions and the T2 sequences pick chronic lesions. Especially, there is something called as the shading sign. Because of the cyclical and different age of the collected blood, a shading sign is considered very, very typical of endometrioma compared to a simple hemorrhagic cyst. Shading sign is absent in a simple hemorrhagic cyst. Not to forget, we have to always rule out other possible differential diagnosis which may be confused or give an overlapping picture with an endometriosis. Some of the other gynecological causes would include pregnancy, sexually transmitted infections, pelvic inflammatory disease, ovarian cyst, ovarian torsion, etc. Gastrointestinal like inflammatory bowel syndrome, food allergies, constipation, worm infestation, etc. Urologic like urinary tract infection, cystitis, and a few others. What are the management goals? The key management goals are: 1, symptomatic relief, because that's what the patient has come to us for. Then we know the nature of the disease. So we need to ensure suppression of further disease progression, at the same time protecting and preserving the future fertility to the best possible extent. So the management starts with the first line medicines, NSAIDs, and combined oral contraceptive pills. As far as the combined oral contraceptive pills are concerned, continuous therapy is said to be better than the usual 24-28 day therapy because it gives better pain control. However, when we are prescribing COCs for any girl, we have to counsel the patient and the parents thoroughly, because this therapy is only suppressive, it is not curative. In fact, the symptoms may recur as early as 6 months of stopping these COCs. And we know that there are certain limitations to long-term use, especially if we are dealing with, for example, the girl may be obese, there may be some family history of dyslipidemia, etc. Progesterone is the third group of molecule which we often use in endometriosis. Progesterone works by the mechanism of inducing desterialization, inhibiting the estrogen-induced mitosis, altering the estrogen receptors as well, and inhibiting angiogenesis and the expression of matrix metalloproteinases. Various progesterone molecules have been used and tried. Most commonly used tablet medroxyprogesterone acetate can be given for 3 to 6 months. One common concern with long-term use of more than 2 years, say, is slight decrease in the bone mineral density, which is partially reversible, which is not fully reversible. Then depomedroxyprogesterone acetate is another option which can be used. Third is norethindrone acetate, which can be considered in the doses of 2.5 to 5 milligram per day for a maximum of about 12 months. And the new favorite molecule, Dynogest, which is often used in a dose of 2 to 4 milligrams per day. And usually 2 years is the maximum duration for which one would consider using Dynogest. If a girl does not respond to the above molecules, then another molecule that can be considered is another preparation, that is the GnRH agonist and antagonist. The problem with GnRH agonists is the very mechanism by which they work. So they suppress the HPO axis, causing profound hypoestrogenism, and therefore they give good suppression of endometriotic lesions and symptoms. So definitely it can be used for initial control. Usual duration is 3 to 6 months with add-back therapy. And in adolescents, it is usually recommended that under 16 years of age, even if we are suspecting endometriosis, GnRH agonist antagonists should not be used. They can be considered in girls above the age of 16 years. The next useful molecule that we have is the oral GnRH antagonist, that is elagolix, which was approved by FDA in 2018. And this new combination of relugolix and the add-back therapy of estradiol and norethindrone has been approved by FDA in 2022 August. A word about elagolix. So a few potential candidates would be those who have endometriosis associated pain, have not responded to or have intolerable side effects with the first line medicines, have progestin resistant disease, or have had some side effects from the oral contraceptive in the past. However, we need to be cautious because it is not recommended for patients with a history of or non-response to GnRH agonists or antagonists in the past. Limit the concomitant use with strong CYP3A inhibitors. Clinical monitoring is recommended, especially if there are other medicines going on. Concomitant use with rifampicin is not recommended. And dose increases of certain medicines like midazolam and rosuvastatin may be considered. Contraindications obviously would be pregnancy in an elderly reproductive age woman or known osteoporosis, severe hepatic impairment. Next comes the role of laparoscopy, which I think we kind of avoid when we talk about adolescent endometriosis. So adolescent endometriosis, if there is symptom persistence, if there is enlargement of endometrioma, or if there is any dilemma of possible malignancy, then these are the candidates who can be considered for laparoscopy. Most important, we have to remember that this laparoscopy if we are suspecting adolescent endometriosis, has to be diagnostic and therapeutic. There is no place of diagnostic laparoscopy anymore in any patient. A senior consultant should be doing it with special experience and expertise in dealing with endometriotic lesions. First port can be infraumbilical, others may be suprapubic to give a more cosmetic appearance. Ideally, we should be removing all lesions and restoring anatomy. Very important, this is the subgroup of patients where Eschere says that post-operative long-term suppression therapy is recommended. And it is also important to discuss with the patients and with the patient and the family the potential risks, the risks of adhesion formation in future, impact on fertility, and the possibility of persistent pain and recurrence. And of course, ERAS protocols should be followed. Enhanced recovery after surgery protocols should be followed to optimize the experience and outcomes of this laparoscopic management. So a few specific points about laparoscopy in adolescent endometriosis. In very young patients, we must consider lower insufflation pressures. We should use the smallest ports possible. There has to be a standardized, consistent method of evaluation for your team. It could be clockwise, it could be anti-clockwise, but there has to be one specific method that you follow so that you don't miss anything. Look at the appendix and diaphragm as well. Then, if you have doubt about the lesion, then take the camera very close to the lesion, that is called as the close tip method, or the under liquid technique for making these lesions look prominent with the refraction. And then of course, careful mapping has to be done. So this first image here is showing clear lesions because in young patients in adolescent endometriosis, we more often come across the atypical lesions. The typical powder burn appearances are not often seen in this age group. These are the red lesions, these are the yellow-brown lesions, and these are what we call as the peritoneal windows. Also, one of the type of lesions associated with endometriosis. Coming to the end of the presentation, so a thorough history, systematic examination supported by appropriate radiologic imaging. Then first line, NSAIDs, continuous hormone therapy. If unresponsive, then consider laparoscopy. If endometriosis confirmed, it has to be see and treat, keeping fertility preservation and prevention of recurrence in mind. GnRH agonists may be considered in girls above 16 years for a limited period of time, or continuous CHT is preferred if the girl is below 16 years. This is a summary of recommendations from the Eschere 2022 guidelines. In adolescents, clinicians should take careful history to identify possible risk factors, may consider endometriosis in a girl who has disruptive pain or pain even with the use of oral contraceptives. In adolescents, clinicians should take careful history and consider following symptoms as suggestive of endometriosis: chronic or acyclical pelvic pain, especially if associated with nausea, dysmenorrhea, dyschezia, dysuria, etc. Cyclical pelvic pain. In the absence of evidence for adolescents, specifically, GDG recommends that before performing vaginal examination and or rectal examination, acceptability should be discussed with the adolescent and her caregiver. Transvaginal ultrasound is recommended if it is appropriate in a sexually active girl. Otherwise, MRI, transabdominal, transperineal scans may be considered. Serum biomarkers are not recommended for diagnosing or ruling out endometriosis. In adolescents with suspected endometriosis, even if imaging is negative, medical treatments not successful, diagnostic laparoscopy may be considered, even though the recommendation is weak, but this is one of the recommendations. If a laparoscopy is performed, clinicians should consider taking biopsies to confirm the diagnosis histologically, though a word of caution, negative histology does not entirely rule out the disease. As far as the treatment is concerned, in adolescents with severe dysmenorrhea, first prescribe hormonal contraceptives or progestins as the first-line therapy. Consider NSAIDs as treatment for endometriosis-associated pain as first-line therapy. In adolescents with laparoscopically confirmed and associated pain, may consider prescribing GnRH agonists for up to 1 year with add-back therapy. GDG recommends that in young women, if GnRH agonist treatment is considered, it should be used only after careful consideration and discussion. They may consider surgical removal of endometriotic lesions. However, symptom recurrence rate may be considerable if surgery is not followed by hormone treatment. So if surgical treatment is indicated, it should be performed laparoscopically by an experienced surgeon and should consider post-operative hormone therapy for suppression of recurrence of symptoms. So let us not forget that endometriosis in adolescents may present as young as 8 years of age. We have documented cases of endometriosis occurring even before menarche. If the pain does not respond to first-line therapies, then operative laparoscopy may be considered. The operating gynecologist should be familiar with appearance of complete spectrum because adolescents tend to have clear red, white, or yellow-brown lesions compared to the blue-black lesions. Subtle clear lesions may be better visualized by under-fluid technique or the closed tip technique. And adolescents with endometriosis require long-term management until the time in their lives when they have completed childbearing. So psychosocial support also is extremely important for this group of young women. Thank you so much for patient listening. Though I myself don't have a lot of experience handling adolescent endometriosis, but I think it is high time that we all become aware of this condition.
Thank you, Deepti, for such an insightful and enlightening talk on adolescent endometriosis. Actually, this topic is often overlooked, but your talk will definitely improve our approach towards this problem with greater sensitivity and knowledge. Thank you, Deepti. Thank you so much.
Thank you, Komal. Ma'am, there is a question. Should I take that right now if we have time?
Yes, ma'am, please. Yes, ma'am.
So somebody wants to know role of Dynogest in adolescent endometriosis. I hope I have addressed that already. So in the standard dose of 2 to 4 milligrams till about 2 years of use, it can be given for adolescent endometriosis. We know that Dynogest has a fairly good safety profile, especially in terms of bone mineral density. And the other progesterone molecules are limited in terms of duration of use. So Dynogest definitely is a promising molecule for use in adolescents.
Fantastic, Deepti.
Thank you so
Well
much.
presented. See, another one point I want to add is nowadays for adolescents, rather than going for what you told, that elagolix and all, that progesterone injection, DMPA. Previously, they thought that the bone marrow density was reduced, but now there are studies which tells that that can be conveniently used. That
Yes,
is
ma'am. It is not as bad as GnRH. So
Yes.
definitely DMPA is a cost-effective, safer, and it is easily available in most of the low resource and government sector institutes as well.
In the government setup, it is available as Antara.
Antara, yes, yes.
Nice. Thank you. Thank you
Thank
so
you
much.
so much, ma'am.
Madhumita, if Neelam
Yes, ma'am.
and Poonam has joined means we can go with the chief guest and guest of honor before
Yes,
panel.
ma'am. Yes, ma'am. Raki ma'am has joined, ma'am.
Poonam,
Good
then you
evening,
go
madam.
with the guest of honor. We will get the first Raki.
Yes, ma'am.
Good
Raki
evening,
ma'am has
madam.
joined.
Dr. Raki, can I have the CV of Dr. Raki? Priya?
Yes, ma'am.
Yes, Dr. Raki is really a backbone of this program. Welcome, Dr. Raki. Dr. Raki is the president of Jabalpur Society and a diploma in advanced gynec endoscopy and trained in microsurgery from FPAI Mumbai, and chief fertility specialist, endoscopy specialist, and she is the life member of IAG, IMS, IMA, IMA, AMS, member Foxy and Jokes, and she is the treasurer of IMA, AMS, and vice president Jokes, and president of Jokes currently. And she has many awards to her credit. And immediately when I called the Jabalpur Society president, Dr. Raki, she immediately accepted to give all the 2 sessions, even the speaker, the chairperson, moderator, and the panelists. And thank you, Raki. Now we need your wishes for the success of the webinar. Dr. Raki, our chief guest has not joined. So we will, you tell your wishes, then we'll go with the panel model.
Okay. Good
Dr.
evening,
Raki,
madam.
welcome.
Thank you so much, ma'am, and thank you so much for your nice words, madam. A very good evening to everyone who is present here. I congratulate you, madam, for arranging this Pinnacle news series since long. And this is 13th webinar. Madam, you are conducting it on every second and fourth Saturday and involving Pan India. That's a great thing. And Madam, we Jabalpur Society is happy to participate here under your dynamic leadership. And Madam, we are happy that you have given us a very good topic, endometriosis, because it affects 1 in 10 women worldwide, and it has devastating effect on sufferers. The problem with this disease is that it gets diagnosed late. So spreading the knowledge among the doctors and patient plays vital role in its treatment. Madam, we have eminent speakers, Dr. Deepti Gupta. She has already given her a very nice talk. And we have Dr. Anu Jain and Dr. Deepti Patel, who are also very eminent speaker. And we have our learned panelist, Dr. Ashita, Dr. Shruti, Dr. Sneha, and Dr. Megha. And I hope this is going to be fruitful and with many take-home messages. And Madam, it's pleasure to meet President and Secretaries of Vardha Society, Ujjain Society, Bellari Society, and our today's expert, Dr. Ramaraju. And it was a great pleasure to interact with Dr. Radhika Gavri Madam and Dr. Madhumita while arranging this webinar. And Madam, your thought behind this news series is novel one. And I wish this webinar a great success. And I wish you all the best for your future endeavors. Thank you so much, Madam. Thank you so much for giving us.
Thank you, Dr. Raki. I will come in person to Jabalpur. Very, very vibrant society. Sure, I will.
Thank you so much.
Thank you, Raki. Madhumita, can we proceed
Yes, ma'am.
with our panel?
Yes,
Dr.
ma'am.
Poonam
Thank you
is
so much,
there
ma'am.
here. Dr. Poonam is if there.
No, ma'am. Yes, ma'am.
No, she is not there.
So,
Madhumita, you introduce the moderators and the panelists.
yes, ma'am. It's my pleasure to introduce our faculty for the panel. We have our expert, Dr. Ramaraju, who's an associate professor at Bellari, and he's also the past president of Bellari Obstetric and Gynecological Society and past EC member of North Zone Kasoga. And he's received the Foxy Future Award in 2017. And also he's received the Professor Sean Ratnam Young Gynecologist Award by AFOG and Amarendranath Dawn Prize for MCH Care at ASCOG. He's also the coordinator for Sexual Health Committee and South Zone coordinator for YTP Committee. Welcome, sir. Next, we have our eminent moderators, Dr. Ranu Jain, who's the assistant professor at Jabalpur and also editor-in-chief of JOGS and past treasurer of JOGS. And she's also the member of the scientific committee and critical committee member of JOGS. And she's won the first prize CS John Award for Best Paper in ASCOG. And she's presented papers in various state and national conferences. We welcome you, ma'am.
Thank you so much.
Yes, ma'am. We have a co-moderator, Dr. Kirti Patel, who's assistant professor at Jabalpur, and currently she's pursuing her PhD at Gynec Oncology, and she's a member of the cancer committee of JOGS, and her area of interest is high-risk pregnancy and preventive oncology. We welcome you, ma'am. Please introduce our panelists, ma'am.
Yeah. At the outset, I would like to thank respected Sampath Kumari Madam, Dr. Madhumita Madam, Dr. Ramaraju Sir, Dr. Rajsa Ma'am, and my very dearmost Dr. Rakhi ma'am for giving me and Dr. Kirti the opportunity and the platform on the national level to be moderating a much difficult topic of endometriosis. Though we are moderators, but we still feel that we are students here learning newer techniques day by day. So it's my proud privilege to be hosting today's webinar, and my dynamic panelists are Dr. Ashita Dubey. She's currently consultant OBGY in Shishu Mangal Hospital, and she is a fellow, and she has won lots of gold medal, and she was a very bright student of ours. Then we have our second panelist, Dr. Sneha. She is consultant OBGY, former SMO in Mumbai. She is a USG trained fetal medicine expert and a very, very loving person, Dr. Sneha. Then we have Dr. Meghna, Dr. Shruti. I call her Chutki, our youngest OBGYN in our Jabalpur OBGY society. She is consultant and PG laparoscopic and endoscopic surgeon, infertility expert, and very vibrant girl. And my last is Dr. Meghna. She is from former resident from Riva, and she has done her fellowship in reproductive medicine and high-risk pregnancy, and she is our newly joined JOG member. I welcome all my 4 panelists. So quickly we'll start.
Good afternoon, respected seniors and everybody who's joined. I would like to first, before we start the session, I would like to thank everybody for this great opportunity that we have
Is
got.
my presentation visible?
No,
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 ma'am.
Dr. Ranu, it is not visible.
Manu?
No, you have your PPT at the back and click the share and then open.
Okay, madam. ये शेयर नहीं हो रहा है
नहीं वो जूम से ही शेयर हो गया है एक सेकंड
कैसे होगा just a second ma'am I'll share
No
it.
problem, no problem.
Yeah.
Yes, go to slideshow. Fantastic. Yes, Dr. Ranu, you can start.
Yeah. वो देना तो जाएगा ऊपर नीचे को
कीर्ति एक बार स्क्रीन पे हाँ क्लिक कर ले फिर मूव करेगा
हाँ जी
इसके बाद क्लिक करो तो बेसलाइन डिस्टेंस ठीक है
जी so to start with, before wasting much of the time, endometriosis is one of the very much yeah. So 1 in 10 women of reproductive age suffer from endometriosis. The prevalence of endometriosis in women with infertility is around 30 to 50%, and on an average, 8 to 9 years it takes to get to a diagnosis, which is a very big time for the patient to have patience regarding her disease, and day by day worsening of the pain is a very troublesome thing for her. So why do we estimate endometriosis? Traditional belief was that it is a surgical procedure and it needs histological confirmation, which is cumbersome. The misconception that menstrual pain is physiological condition. So she has to suffer with it. The third is dysmenorrhea and pelvic pain are not necessarily due to endometriosis. And it really took a lot of time for we as clinicians, as well as the women suffering from it, to understand that this is a disease and which needs a treatment. So pathogenesis is still a mystery and evolving extensive medical and surgical treatment. No reliable and early diagnostic tests are present. Average time lapse is too high. Therapies are only symptomatic, and high and social impact impairs life. So, quickly coming to our first case, I would like Ashita to take up this case. Kirti, could you please tell us for us?
So our first case is Miss X, 19 years age, college going girl. She is unmarried and come to us with complaint of increasing pelvic pain and spasm during periods. Initially, the patient ignored the pain. Now the pain has increased to the extent that she often skips college on days of her periods. The pain has progressively increased over the past few months. About her previous treatment, she was given a trial of NSAID, but it provided only partial relief from the pain. And her current preference is she wants pain relief and improvement in the quality of life. So, how will you approach this case? What will be about your relevant history, examination, and investigations?
Hi everyone, am I audible?
Yes, you are audible.
So, as we all studied in Deepti ma'am's lecture, it was explained very beautifully. She is an adolescent girl. So, first of all, we need to confirm her diagnosis. We need to take a thorough history. We need to know her family history. And we need to rule out other medical causes of chronic pelvic pain as well. And when we've done that, then we move on with the further investigations in this patient. Then we have to look for some specific symptoms related to endometriosis. So one of them is that the pain is mostly during the period time, and it progressively increases with age. It is a very classical symptom of endometriosis that it goes on increasing with age. Then we look at other symptoms as well. She may have other symptoms such as dyschezia or bowel symptoms, some urinary symptoms. So we need to look at all these symptoms and then we go forward with examination of the patient. So since she's a 19-year-old girl, we can do a per abdomen, and if she allows, we can do a per rectal examination as ma'am suggested previously. And the investigation of choice in these patients, like previously it was said that laparoscopy was gold standard, but nowadays, according to the recent guidelines, a laparoscopy is not needed to make a confirmatory diagnosis. We can first go for a good ultrasound, and if possible, we can go for a transvaginal ultrasound, or we can go for an MRI for further diagnosis.
Good. Okay, Dr. Ashita. So about the history, good history, and about the symptoms, signs, family history of endometriosis in the first degree relatives. Then we will go for the symptoms, uh, examination, and then diagnostic. About diagnostic, we will go for transvaginal sonography and MRI.
Here, I would like to add a word for transvaginal sonography since she is an unmarried girl. So, we might take her consent up, and after her due consent of her parents or and her, we'll proceed for transvaginal ultrasonography because it is far better than transabdominal. Yes. Start moving.
Hello.
Just a second, ma'am. It has got stuck up. Just
Okay.
फिर से शेयर नहीं मैंने शेयर
The pelvic issues, ma'am.
Hello?
Yeah.
Ma'am, any issues?
No, madam, no, madam. यार मम्मी तो यहीं रुकता है ना, वो नहीं कुछ कुछ हो रहा है उसमें, शेयर नहीं हो पा रहा है वो। स्लाइड तो यही रहना।
हाँ कहाँ से
करंट स्लाइड, हाँ इसके आगे हाँ। Now, my second question is for Shruti. How do we investigate this girl, Shruti?
Yes, ma'am. Ma'am, am I audible?
Yes,
Yeah.
ma'am.
Yes, ma'am. Ma'am, so since we are talking about... Hello?
Yeah, yeah.
Yes, yes. Ma'am, since we are talking about a 19-year-old girl right now, and as Deepti madam's lecture already told that earlier, as we knew, laparoscopy was gold standard. But now we have such good sonography machines. And for a 19-year-old, we can use a good 3D machine. And usually when we want to see an endometriotic lesion on a 3D sonography, any sonologist or any gynecologist who is doing a sonography, there's something called as soft markers. First, when you're doing a sonography or you're doing an examination, there is tenderness, or if you're doing a vaginal, there's something called as a sliding sign if you're going for a vaginal sonography. And then on sonography, you see low level internal echoes with a thick cyst wall seen, ma'am. You can differentiate between hemorrhagic cyst and endometriotic cyst like that. You can see a thick wall on sonography, and usually it's easily when there can be, you can put Doppler also nowadays. Some people say that with Doppler also you can identify, but I think with a 3D sonography, low level internal echo seen on a cyst with thick capsule, I think that can really help us. And if sometimes when we want to see, usually in a 19-year-old, we won't find deep infiltrating, we usually don't find, but MRI also can be a very good diagnostic tool for us to differentiate between superficial and deep infiltrating endometriosis, ma'am.
Yeah, very good, very good. Now moving ahead. Manu, ये फिर हटा।
yeah
Okay. हो रहा है।
रानू, अगर स्लाइड शो में दिक्कत आ रही है तो नॉर्मल व्यू में भी रन कर सकते हो।
That is what मैम वही कर रहे हैं।
Ma'am, is coming correctly only. Is coming, ma'am, correctly only. We can able to see the slide show only.
No, but it's
slide
not
show,
moving
but
ahead,
it's
ma'am. It's
actually, Ranu, you need to click on the screen. वो अपन जब slide show पे ऊपर जाते हैं ना पावर पॉइंट पे,
Yeah,
it's coming, ma'am. It's coming correctly. We can able to see your slide.
no, but ma'am, it's not moving actually.
You want
It's
to move
paused.
Okay, if it's not moving, then go to normal view and then move your slides. Not a big deal. Just press it. Next, ma'am, the down arrow. Arrow is there, no 4 arrows. Go to the right arrow. Right arrow. It's now is moving.
Yeah. Is there any? Now can you see?
Yes, ma'am.
Yeah. Is there any role of laparoscopy in the diagnosis of endometriosis, Meghna? Do we have Meghna with us? Dr. Meghna?
I'm audible.
Yeah.
Yes, you are audible.
Good evening, respected seniors. There is a role in endometriosis for laparoscopy.
only when there is it's not responding to medical treatment or empirical treatment, then we can go for the diagnostic laparoscopy. And in diagnostic laparoscopy, ma'am, we can see the initial red flame.
Hello.
Yes.
Yeah. Now, what should be the primary role of laparoscopy? Is laparoscopy is no longer the diagnostic gold standard, and it is now only not only it is not recommended as the only gold standard. So we need to combine with our other clinical findings, our histological findings, and laparoscopic identification of endometriotic lesions is confirmed by histology, although negative histology does not entirely rule out the disease. This we have to keep in mind. And if we go for laparoscopy, we see superficial lesions like powder burnt appearance, gunshot, dark brown puckered lesions, red implants, ovarian endometriomas showing chocolate cyst. And if we are suspecting deep infiltrative endometriosis involving bowel and bladder, consider pelvic MRI before planning for laparoscopy. During laparoscopy, consider taking a biopsy of a suspected lesion. That is a real must thing to do now. Now coming to the biomarkers, the measurement of biomarkers is in endometrial tissue, blood, menstrual blood, and uterine fluids to diagnose endometriosis. The latest guidelines are not recommending it. CA 125 also doesn't play any role. It is non-specific. So this we have to keep in mind. Now, what should be the primary goal while treating endometriosis in unmarried young girl? Ashita, would you like to take up?
So, ma'am, the primary goal in such a patient is first of all, she needs to be counseled about her condition that this is a chronic condition and there is no permanent cure. Secondly, in such a case, the main goal is relieving her of the pain and improving the quality of life. But with the same, with also doing this, we have to keep in mind that we have to give something which she is going to take for a prolonged period of time. And also we have to keep in mind that we have to restore her fertility. We do not want her to lose her fertility, and also as we talked about using GnRH antagonists and agonists, that they have a bone demineralizing effect. So we do not want to go for something that has a chronic health issues that can cause chronic health issues in such a patient. So we also have to avoid a very hypoestrogenic state for this girl. So
Yes, you would like to add something?
So the first line, as you have already said that she has tried NSAIDs. So the second line, we can go for oral contraceptive pills or progesterone therapy in such a patient. Because as we have already discussed that progesterones have lesser side effects and the longer duration. Then we have discussed about Dinoges, that it can be given for 2 to 3 years. At a younger age group, we have talked about DMPA, that it can be safely used nowadays. So these are better modes of therapy in this case. And GnRH antagonist agonists will have to be kept in store for a later use, or for in severe cases where all these therapies have failed.
So very well taken up, Ashita. We have always with a basket of treatments available for a young girl who is unmarried, and let her choose what she prefers choosing. And basically, our aim is to give her improved quality of life with minimum pain. Okay, so endometriosis should be viewed as a chronic disease, and our goal is to maximize the use of medical treatment and avoid repeated surgical procedures. What are your main decision driving factors, Shruti?
Yes, ma'am. Ma'am, so I think one of the most important, there are 5, 6 things which we should keep in mind when we are deciding for a patient for. So, ma'am, age is one very important factor. Uh, our decision making will change completely for a 19-year-old than somebody who's in the reproductive age planning for fertility, and somebody who's in a perimenopausal state or or just about to get menopause. So age is one of the most important factors, I think, which we have to keep in mind. Otherwise, other things are, ma'am, like clinical features. We have to always keep in mind about the clinical features. Is it this urea? We need to work on the anterior part or the posterior part, or what are the preferences? There are some patients who prefer ki ma'am, I cannot be it will not be possible for me to have a medicine every day. Can you give me an injectable? So ma'am, I think preferences of the patient also matters. So one very, very important thing that we have to keep in mind is the severity. Sometimes we can't think about preferences and clinical features. If it is severe, the patient is actually suffering, then we probably have to give something which the patient might not choose but will help her out more. And the duration of the disease, the duration of the drug, if the patient will be able to take that drug, will it have a negative impact more rather than having a positive impact on the patient's body? So the basket of medicines that we choose upon all, we keep in our mind all these factors, and then we choose the drug which will be more suitable for our patient, ma'am.
Yeah, it's very well taken up. And one very important thing, we need to look for the pocket of the patient also, Shruti.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Very important. Sorry, guys. Yes, ma'am. Pocket of the patient is very important.
Yeah.
Yes.
What are the treatment options, medical or surgical? Like we might take up with this perspective of the patient.
Yes, ma'am.
Shruti?
Ma'am. Yes, ma'am. Ma'am, so I think if, like we were discussing, we already know if the symptoms are simple system, the patient just says that she just has dysmenorrhea, a good NSAID or a COX-2 inhibitor, a good pain relief can just do for the patient, and we don't need to go deep on a deeper level to treat the endometriosis. Ma'am, as then comes second role comes of the combined oral contraceptive pill. There are excellent combined oral contraceptive pills available. They are safe, and the recent studies tell us that for a oral contraceptive pill or a DMP injection, if you're just scared about the bone mineral density, supplement the patient with a good vitamin D and a calcium supplement. So, so the patient will not have the bone mineral density issue and will be relieved also. Ma'am, then I think, as we know, we have great GnRH antagonist and agonist like leuprolide or elagolix available. And women who are patients who are not teenagers, patients who are actually suffering, we have seen, even though people talk about GnRH in the negative sense, but ma'am, elagolix also has given excellent result for dysmenorrhea. Means if you supplement it rightly and the patient takes it in the right way, so a good antagonist also can be used depending on the patient preference, her reproductive desirability. And then above that, ma'am, then probably we'll have to think about surgical interventions. Dynogest, as madam talked about, Dynogest is one very important drug which is safer, can be given for a longer period of time. And then we come to surgical management, ma'am.
Okay, okay. So now Meghna, role of Luna or PSN.
Ma'am, laparoscopic uterosacral nerve ablation is not found to be additionally giving any benefit to the patient along with laparoscopy. And ma'am, PSN, we can try it. Presacral neurectomy, we can try it, ma'am, when endometriosis is associated with midline pain. But there are other complications which are associated with these procedures, like infection, chances of bleeding, and after the procedure, there are chances of urgency, urinary frequency.
Yeah, very well said. So the latest tertiary guideline says that both these are not of much benefit nowadays. Okay. So quickly we take up the other question. Now, a word on the role of the counseling. I might take up this question because of the glitch which is going on in my PPT. Sorry for that. the role of counseling nowadays is playing lot of important role, because these young girls are so petrified with the pain that they sometimes come to us ki, we don't want to see the future. What will happen to our fertility? What will happen to our uterus? We just want a pain relief, and that we want it now. So your counseling, your assurance as a clinician plays a pivotal role. So counseling is a must before prescribing her any medication or giving her a guideline about surgical procedure or about her infertility concern, whatever is her cause of concern, counseling is a must take home message. So role of fertility preservation in endometriosis in adolescents. Sneha have joined. Sneha, do we have you with us? No, I think she was stuck up in some emergency. Ashita, would you like to take up this question?
Yes, ma'am. So the role of fertility preservation in endometriosis in adolescents. So definitely fertility preservation is an option. They can go for oocyte freezing for future, but there are no concrete studies. We do not have that many cases and that many concrete studies whether it will give a positive result or whether this should be a norm for every girl suffering from endometriosis who is diagnosed in adolescence. But we can give this option to these girls that they have this option and they can look into it and then decide accordingly. So, because definitely endometriosis is associated with chocolate cysts and decreasing ovarian reserves, it is associated with many fertility issues in the future. So, we can give this as an option to these girls if they are willing for oocyte preservation.
Okay, okay, Dr. Ashita, very good. So there is a lack of robust evidence concerning the usefulness of the fertility preservation in adolescents with endometriosis. The GDG, as per ASHRAE guidelines, GDG recommends that adolescents with endometriosis are informed of the potential detrimental effects of ovarian endometriosis and surgery on the ovarian reserve and future fertility. Fertility preservation option exists, and the GDG recommends that adolescents are informed about them, although the true benefits, safety, and indications in adolescents with endometriosis remain unknown. Next.
So to summarize, the management of endometriosis, we'll have our clinical examination, our imaging parameters with us, and then we'll decide whether she wants pregnancy immediately or not. And accordingly, we'll plan her further management with either ART or surgery if she requires pregnancy, and if she doesn't require, then we might go up for medical treatment, which may be long term or short term according to her demand. So we are taking up the second case now. I think I would like to start up with the Shruti this time. So Shruti,
Yes, ma'am.
we have Mrs. X. She's 27, trying to conceive since 1 year and getting very anxious. She is behind Google about endometriosis and subfertility, and she's all come well prepared with firing you with her Google knowledge. And her husband's semen parameters are normal. Her TSH is 2.3, prolactin is 20, her fallopian tube is patent, her serum AMH is 2.3, but she has a fimbrial block on the left side with bilateral endometriomas of 4 and 3 centimeters. Already she has taken letrozole. How will you proceed?
Yes, ma'am. Ma'am, so since we have such a good knowledge about our patients and we know there are 2-3 major things which will just help us decide what we need to do. We can divide it. If this patient didn't have a fimbrial block, for example, ma'am, then probably I would have told her about a systematic ovulation induction followed by a IUI with an experienced hands in a place where which has an embryology department, which has good semen sample preparation. So an IUI could have really helped with that patient. But ma'am, since this patient is having a fimbrial block, and currently, since and we can first go for a diagnostic hysterolaparoscopy for her, ma'am. So a diagnostic hysterolaparoscopy can help us with her. We can either correct the block for her and understand. We can also, and if there are experienced hands available, we can work on the bilateral endometriomas also. But ma'am, a lot of studies are saying, ma'am, I would suggest a DHL for this patient because there is a fimbrial block, and I want to work on the fimbrial block. Otherwise, if the fimbrial block would have not been there, nowadays studies say that even if there are endometriomas present, you can do a good stimulation, you can do a good IUN, and the patient can still conceive. Second thing is, if the patient post DHL still has the block, then I would suggest the patient to go for a good IVF and plan for an IVF cycle, ma'am. If the block is not really helping with, if DHL doesn't help with the block.
Ashita, would you like to add something?
Oh, okay, ma'am. So what?
Ashita, we cannot hear you.
Hello,
Ha,
am I
say better.
audible? Yes.
Yeah.
So what happens with these cases, that whenever we see a patient with bilateral endometriomas and a fimbrial block, so firstly, what we need to understand is, if she wants a child right now, so there is no role of giving her oral contraceptives or GnRH agonist as we give for reducing the size of endometriomas, because right now our focus is she wants a child. So we will not focus on that. The only reason for going for a surgery for endometriomas is pain. Whenever there is extremely severe pain, or when the size is too much that she is not able to bear it, then only we go for surgeries. Otherwise, we should avoid surgeries, because these surgeries have mostly resulted in decrease in almost 20 to 30% of her antral follicular count or her AMH. So it's better we avoid a surgical intervention in such cases. Then whenever we go for infertility treatment, three things are most important: the male factor, the open tubes, and and the ovulation. So if the male factor is okay, the tubes are open, then definitely she can go for ovulation induction with IUI. We need to look for patent tubes in such cases. And if there is the endometriosis is not very severe, it's grade 1 grade 2 endometriosis, and if it's a small fimbrial block, we can definitely treat it by laparoscopy and go for this. But if it is a severe case of endometriosis, then better go for in vitro fertilization treatment. Then one more important factor in such cases is we also look for patient profile, whether she's been married for like 8 to 10 years, or whether she's married for like 1 or 2 years. So we have to also consider these issues in such cases, whether if she has a prolonged infertility, she's been wanting a child, so better than go for in vitro fertilization rather than taking more time. We have to also look for her age, if she's above 35 years of age, or whether she's 28
Ours is
years of age.
27, Ashita. Ours is 27. Probably married for a year or two. So maybe you can wait for
Yes.
direct IVF, I think. Hannah,
Yes.
Meghna, would you like to add on something? Any comments?
As all the things are already mentioned, but I just want to add some things.
Meghna, you are not audible. Unmute yourself, Meghna. Unmute yourself.
Ma'am, am I audible, ma'am?
Yeah.
Yeah, ma'am, as mentioned in this case, it was not strictly observed with follicular monitoring. The patient was given just the letrozole, and it was not monitored cycle. So I would like to monitor it with follicle size, folliculometry, LH search, and then timely IUI, which may be beneficial in this case.
So we have the points from all the three of our panelists from here. So I think we can sum up this case with IUI, ovulation induction with IUI, and if it fails, then we might go up for the IVF if patient wants it. So let us see what the review, ASHRAE review says. Based on the result of Cochrane review, suppression of ovarian function by means of danazole, GnRH agonists, progesterones, OCPs to improve fertility in women with endometriosis is not effective and it should not be offered for this indication alone. Next. Surgical excision of endometriomas is associated with decline in ovarian reserve up to 38% reduction in AMH after ovarian cystectomy. The effect of surgery on ovarian decline is greater, especially if the pathology is bilateral, and repeat surgery in cases of cyst recurrence. The damage inflicted by surgery to the ovarian reserve can occur as healthy ovarian tissue is inadvertently removed during ovarian stripping, as well as through vascular compromise, thermal damage, and local inflammation. So this we have to keep in mind before we plan for further management. Now, what do we do for this? Should we drain? Should we excise? Should we ablate? Shruti?
Yes, ma'am. Ma'am, so always a good cystectomy is preferred over drainage and
Yes.
ablation, ma'am. Yes, ma'am. Always, ma'am, because first thing, the recurrence. If we just drain, recurrences can be a very big possibility. Also, ma'am, ablation can, ma'am, decrease in lowering of the AMH and ovarian reserve. Ablation can do cause that. So, ma'am, I think for always, if you're choosing to go for surgery and if you're going in with a laparoscopic preference, then always cystectomy over ablation and excision, ma'am.
Yeah, very good. And CO2 laser vaporization is better than monopolar electrocauterization. Okay.
Monopolar
Next.
electrocauterization.
Yeah.
Yes.
Next.
Yes.
Precautions to be taken during laparoscopic surgery, Shruti?
Yes, ma'am. Ma'am, so I think firstly, all vascular planes should, whoever, first we have to know it is very easy to say that, yes, I'm a laparoscopic surgeon, but not have the experience to work on endometriosis. I think you need to, it's a long learning curve and everybody needs to first understand before taking up an endometriosis surgery, because you can do more harm than actually treat a patient if not done right. And I think laparoscopically, TLH and endometriosis is very different. So first you have to know the vascular planes very well. Second is, ma'am, you have to preserve the place near the hilum. I think that is one very important part that an endometriotic surgeon should know. Third point is, if you're going in to do a cystectomy, do it properly and take out all possible endometriotic lesions that you can't just take out one and then say that yes, you've done an endometriosis. Whatever is visible and whatever can be done, so you have to have that expertise to take all those out. And I think, ma'am, I think avoid spillage, very important, of the endometriotic contents. And you should all, I think the fifth point is, I think whenever we are learning laparoscopy, the first thing a teacher teaches us, beware of the ureter, because endometriosis always is associated with adhesions, ma'am, and those adhesions lead us to our the beloved ureter. And I think we should be very scared of the ureter when operating on an endometriotic lesion
Very
or
well taken up,
endometrioma.
Shruti. And I think laparoscopically doing endometriosis needs very expert hands. So take up any endometriosis or endometriomas, either bilateral or unilateral, with a senior or with someone very expert in doing it. Next. Role of post-operative hormone suppression. Meghna, would you like to take this?
Yes, ma'am. Ma'am, Operative hormone suppression, ma'am, we can divide it in two phases. If the patient wants fertility or she just wants pain relief. When the patient wants pain relief, ma'am, we can prescribe her medical treatments to avoid the recurrence. As we can see, under the 5-year recurrence rate of endometriosis is around 40 to 50%. So for pain relief, we can prescribe her on hormonal treatment or painkillers. But ma'am, if she wants to conceive, ma'am, then we should not go for the post-operative hormonal suppression. We can either go for ovarian stimulation accordingly, ma'am, but we should not be prescribing a post-operative hormone suppression.
Okay, good. Next. Role of EFI in deciding the management. Ashita?
So, ma'am, endometriosis fertility index, it's a index where we use different methods, and then we decide on we can predict the fertility of a patient in such a case. So it has different parameters. First one is we look at the least function scores. It is the score, we actually look at the anatomy of that patient. We look at the fallopian tubes, the fimbria, the ovary, and accordingly on both sides we give a score, whether how much they are functional. If the function is completely normal, we give a score of 4, and if it's completely absent, we give a score of 0. So one is the least function score. Then the second thing which is included is the EFI. We calculate the EFI. We take in account the age, then the years of infertility, whether she had a prior pregnancy or not. Then accordingly we calculate the score. The histological and the surgical scores are totaled, and it gives the final EFI scores. So what we have actually seen is the when when a person has a higher score like 8 to 10, the chances of a pregnancy is almost 80 to 90%, and with a lower score it is much less in the next few years. So that is how we can actually, it helps in giving a predictive outcome to the patient, that what the treatment outcome could be and what her future pregnancy outcome could be.
Yeah. So, according to the latest guidelines which are coming up in X-ray guidelines, lots of scoring systems are coming up, and day by day they are getting upgraded, like revised ASRM scoring systems, Enzian classification for infiltrating endometriosis. All of them are coming up with some or the new idea about scoring, so that the prognosis of the endometriosis can be bring out, and it can be conveyed to the patient regarding her fertility potential, regarding her pain management, regarding her surgical what you say management, that how deep we should be removing, what should be the planes we should be deciding, what should be our operating ways which we are doing. So these, among all these, the Eshe says the best, and I think the easiest which is coming out, which we can keep it on our OPD tables, is the endometriosis fertility index, which combines both, as Ashita told, historical factors and surgical factors, and we can tell the prognosis to the patient. It is very easy for us with this scoring system to explain the patients that, see, you have these findings, and with this calculation your score comes to be this, and we can very well without wasting the time of the patient, because as we have already discussed that it is a long span of time, and patient is already tired changing doctors to doctor and taking so much of medication, and some advisor pain relief with OCs or with hormones or with other herbal pills and everything, some advisor with surgery, should she go, should she not go, uh, all the dilemma with goes with her whenever she goes to one doctor to the other. So I think this fertility index helps us in prognosticating the further management of the patient. Next. 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 So we will plan her management for this patient, she's infertile. We have given her with different options. Hormonal treatment we don't recommend for her. She might go for surgery if she wants, or medical assisted reproduction for her. Okay. Now coming up to the ultrasonographic findings. Next, beta. So this I just took up this slide so that we all should know what are the ultrasonographic features which we should keep in our mind while we are going through endometriosis. Routine evaluation of uterus and adnexa, plus sonographic signs of adenomyosis, presence or absence of endometrioma should be our first step in evaluation. Then evaluation of transvaginal sonography for soft markers, that is site-specific tenderness and ovarian mobility. Then assessment of status of POD using real-time ultrasound-based sliding sign, and then assessment of the deep infiltrating endometriotic nodules. Anterior and posterior compartment. This is a small picture showing how should we proceed for all the examination parameters. Next. Now, what is the expected management? OI or OI with IUI? Shruti, would you like to take up?
Yes, ma'am. Yes, ma'am. So, ma'am, usually now whenever we are reading about endometriosis and we are reading all the studies, everybody is suggesting that we should always do an ovulation induction with an IUI, because since the patient has been already suffering, we have to help her out as soon as possible. We can just go with the ovulation induction, but I think ovulation induction with an IUI is the preferred protocol that needs to be chosen instead of an expectant management or an IUI alone. So you should do an ovulation induction with an IUI. And ma'am, I think yes, ma'am. I think ovulation induction alone or IUI alone is not chosen. Both should be combined. This will help out the patient more, ma'am.
Next. So evidence says in infertile patient with minimal and mild endometriosis with confirmed tubal patency and normal seminal fluid parameters, IUI with ovarian stimulation using gonadotropins may be performed, especially following surgical management of minimal and mild endometriosis. The efficacy of IUI as a treatment option for infertile patients with moderate and severe endometriosis and patent fallopian tubes remain unclear. And if there are additional risk factors such as advancing maternal age, comparatively IVF appears to have a better pregnancy rate.
Yes.
So, our third question, she's 35 years, Mrs. Y. Married for 2 years. Her sonography report is showing 5 centimeters unilateral endometrioma on the right side. Her AFC is right ovary 3 and left is 3. Her AMH is 1.4. Her husband's semen analysis is normal. HSG or laparoscopy, Meghna?
Yes, ma'am. Ma'am, this is a patient with advanced maternal age, already 2 years of marriage, and she is a definite case of infertility, ma'am. First, I would like to proceed with a elaborated history and physical examination, and then the investigations, ma'am. For the investigations, am I audible?
Yeah.
So, ma'am, here it is a 5 centimeter endometrioma. So first we should counsel the patient. If we go for laparoscopic cystectomy, then there are chances for decrease in ovarian reserve, decrease AMH for the future fertility. So first we should counsel the patient for all these things, ma'am. And secondly, if we don't remove the endometrioma, we go for IVF. Then during the oocyte retrieval, if we accidentally puncture the endometrioma, there are chances for its spillage and later on chances of pelvic abscess and acute abdomen are also there. So here I would like to further progress with laparoscopy. and laparoscopic cystectomy for this patient.
Okay. So clinical variables to be considered while deciding whether to perform surgery or not are here. Previous interventions for endometriosis, favors expectant management, ovarian reserve, whether it is intact or damaged, pain symptoms present bilaterally, monolateral disease favors surgery, sonographic features of malignancy are present or absent, growth, which is a rapid growth. So these are the different factors which we should consider before planning for the surgery. Preferred line of management, IUI or IVF? Shruti?
Yes, ma'am. Ma'am, for this patient, if the patient is affording and since it's advanced maternal age, firstly, we would like to tell her and counsel her that if you can, you should go for an IVF cycle, which will be benefiting you more because, ma'am, surgery is only done for either the patient has too much pain or there is difficult if you're going for an IVF cycle, there is difficulty in taking out the follicle, then probably cystectomy should be chosen because the follicles cannot be retrieved and that endometrioma is so big. So if patient is comfortable, they can go for an IVF. It's the easy way out. But if they say they want to try more and they want to go the natural way, then probably a cystectomy and then post that an ovulation induction with IUI can be done for that patient, ma'am. So we can choose according to the patient's preference.
Yes, Dr. Shruti. So as per the guidelines, in an infertile woman with revised ASRM stage 1 and 2 endometriosis, clinician may perform IUI with ovarian stimulation instead of expectant management or IUI alone. Although the value of IUI in infertile women with ASRM stage 3 and 4 endometriosis with tubal patency is uncertain. The use of IUI with ovarian stimulation could be considered. ART can be performed for infertility associated with endometriosis, especially if tubal functions are compromised. There is associated male factor infertility, or in case of low EFI and or other treatment have failed. Next. In which cases of endometriosis would you directly advise IVF, Ashita?
Ma'am, in cases when there is advanced maternal age, there is prolonged years of infertility, the ovarian reserve is less, the male factor is also compromised, then the tubal factor is also compromised, there is decreased tubal function. And previously, if we have tried IUI and they have failed, previously the patient has undergone multiple surgeries, then we can definitely go directly for IVF in such cases.
Yeah. We have not taken up too much of IVF questions actually because both of us are not experts in this. So maybe in the upcoming webinars, maybe Deepti madam or any of our infertility experts will take up those IVF panels. Preferred protocol for IVF in patients of endometriosis, Ashita, please continue.
So in such a patient, so as we have already discussed, we will not go for ovarian suppression in the previous cycle. We will directly go for stimulation. We can go for either an antagonist cycle or an agonist cycle. Both have given good results. And usually nowadays, most of us are practicing antagonist cycles. So we can go for that. And what we usually do in such cases with endometriomas, we can also go for drainage of that endometrioma in just the previous menstrual cycle, and in the next cycle we can stimulate and retrieve the oocytes. So just the drainage helps in two ways. First, it the physical issues with retrieving the oocytes and which we have with the big endometrioma, that is solved. And secondly, we do not also affect the ovarian reserve. So in such cases where there is definitely we are going for an IVF, we can go for a drainage of the endometrioma in the previous cycle.
Okay. Very well taken up, Ashita. So ART can be performed for infertility associated with endometriosis, especially if tubal function is compromised, if there is male factor infertility in case of low EFI, or if other treatments have failed. A specific protocol for ART in women with endometriosis cannot be recommended. Both GnRH antagonist and agonist protocol can be offered based on patients' and physicians' preference, and no difference in pregnancy birth rate has been demonstrated. Women with endometriosis can be reassured the safety of ART since the recurrence rates are not increased compared to those with women not undergoing ART. In women with endometrioma, clinicians may use antibiotic prophylaxis at the time of oocyte retrieval, although the risk of ovarian abscess formation following follicles is low. So the determinants of success of IVF is age, her serum AMH levels, her interfollicular count, deep infiltrating endometriosis, her stage 3 and 4 endometriosis, number of attempts, previous surgery, and male factors. Yeah.
Is there any role of frozen embryo transfer? Hello.
Yes, ma'am. Ma'am, according to the studies, different studies that have been going on, they say that frozen embryo transfer is preferred over fresh embryo transfer because it has higher clinical pregnancy rates and higher birth rates, ma'am. So they say that frozen embryo transfers have been giving better results than fresh embryo transfers.
Yes. So, as per the studies, cryopreserved embryo transfer better reproductive outcome in terms of higher cumulative pregnancy rate, higher live birth rate in compared to fresh embryo transfer with separation with GnRH analog.
Next. So, taking up our last case, a 44-year-old Paraval living one with previous one LSCS, last childbirth 14 years back. She has severe dysmenorrhea, pelvic pain, and dyspareunia, has undergone surgery twice for endometriotic cyst in the past. She has failed medical management and no relief with LNG IUS. Her sonography shows bilateral endometriotic cyst and adenomyosis, definitive management, and post-surgical HRT. Anyone among all three of you who would like to take up?
Ma'am, I think yes, ma'am. Yes, ma'am. Ma'am, a very definitive answer for this will be a total laparoscopic hysterectomy with a bilateral salpingo-oophorectomy, ma'am. We know she's completed her family. We know that now the ovaries are causing more problem than helping the patient. So I think BSO with a TLH is important in such a patient. And ma'am, then probably we can supplement with rather than an unopposed estrogen, we can go for all the climateric effects. Tibolone can be used post TLH and BSO, ma'am, for early or operative menopausal symptoms.
Yeah, very well taken up, Shruti. Our main motto should be to allay her fears, allay her suffering, allay her pain. And she has suffered a lot, and I think we should always go for a definitive treatment when the patient has a prolonged disease. And for such patients, TLH with BSO suffice for her sufferings. And definitely we can add Tibolone with her and calcium and vitamin D3 supplements and give her a good quality of life. Post-operative recurrence rate is 21% at the end of 2 years and 40 to 50% at the end of 5 years, even in the expert hands. So we have to tell a word to our patients. Endometriosis occurs because of the underlying pathophysiology that cannot be corrected. So we cannot 100% assure our patients that everything will be fine. And we have to look out. I think abdomen is a Pandora box, and we need to check out everywhere about the deposits and should be removed as much as deposits as possible when we open her up. So the risk factors for recurrent endometriosis are younger age at the time of surgery, AFS revised score more than 24, bilateral chocolate cyst, size of the endometriomas, preoperative cyst rupture, type and extent of the surgery. So this we should always keep in our mind. So before we conclude, there are the highlights which I would like to share. And there is a lot more. I think we have a whole book on endometriosis, and the time is very short, but we need to wind up. Maybe we can take one more session if, of endometriosis, whatever is remaining, maybe in the next coming Pinnacles. So,
Dr. Ranu, 1 minute. Can you get the expert opinion from Ramaraju? He is there,
yes,
no?
yes, madam. I was just
Ask
coming
him to
to
give
it
the
with
final
this. This
conclusion.
is my last slide, and with this, sir is going to guide us, madam, because he is
Okay.
the expert. A diagnosis of endometriosis should be already suspected among adolescent and young women with severe dysmenorrhea.
There is no longer need to perform laparoscopy just to confirm and staging of endometriosis. Endometriosis can be accurately diagnosed non-invasively by clinical presentation and imaging. The choice of endometriosis treatment is based on the lesion, patient characteristic, patient's age, previous response, tolerance to medical therapies, and reproductive plan are the factor to consider for the management of endometriosis.
Now I hand over my panel to respected Dr. Ramaraju, sir. Whatever mistakes we have committed, sir, please give your word and just give your briefing. Dr. Ramaraju, sir.
Sir is here only, ma'am. Sir is muted. Sir, yeah.
I would like to thank Sampath Kumari Madam and all the for the opportunity, and this is a wonderful panel discussion, and very well moderated by Ranu Madam and Kriti and all the panelists. And nothing much to add, but we had a wonderful discussion. So as we have highlighted here, these are the same principles we follow, and hope for we'll have a one more webinar on the part 2 of this one. Okay.
Definitely, sir. It
Yeah,
was
definitely,
too
because
much, and to wind up in just 40 minutes
it's
was a
a
really tough
Herculean task.
task for
Yeah,
both me
definitely,
and Kirti, sir.
definitely, yeah.
Fantastic, Dr. Ranu. And
Kriti, yeah.
that panelist also very active. And Ramaraju, thanks for your final word.
So
Thank
this
you,
is
madam.
the journey of our poor endometriosis women. She starts and she goes on, and we as clinicians, I think we should pledge that somewhere her suffering stops and we serve her for a better life, pain-free life. Thank you so much.
Yes, yes.
And thank you, madam, for giving me and Kirti on behalf of Jabalpur. Thank you so much for giving us, both of us, the opportunity.
Thank you so much, sir. Thank you so
And
much.
I also want to thank
Thank you.
Rakhi ma'am. Rakhi ma'am, are you with us? Thank you,
Yes,
Rakhi
yes, I
ma'am,
am there. I am there.
for giving me and Kirti the opportunity to be the host.
You both did very good job. Good job.
Fantastic
Clapping
job.
to
Thank you.
all of you.
Thank you, ma'am.
Thank you, ma'am.
Thank you, sir.
Madhumita?
Thank you, Radhika ma'am.
Yes, ma'am.
Thank you, Sampath ma'am. Thank you.
Yes,
Thank
we'll
you,
go with
Thank
a
you.
vote of thanks by
Yes.
Madhumita Radhika.
Thank you so
Fantastic.
much for the excellent panel, ma'am, covering all the clinically important topics. So, coming to the official vote of thanks, first and foremost, I would like to thank Professor Dr. Sampath Kumari, ma'am, for bringing us this wonderful webinar series. And I would like to thank the 4 societies involved, especially the Jabalpur Obstetric and Gynecological Society, President and Secretary Dr. Rakhi Bajpai and Dr. Komal Jain, Varda Society, Dr. Poonam and Dr. Shilpa Rod, Ujjain Society, Dr. Sangeeta and Dr. Raj Kanwal, Bellary Society, Dr. Jyoti and Dr. Anupama for your involvement in this webinar. I thank our chief guest, Dr. Poonam, and our guests of honor, Dr. Rakhi Bajpai and Dr. Sangeeta, for your blessings. I would like to thank our chairperson for this first session, Dr. Komal Jain, and our excellent speaker, Dr. Deepti Gupta, for that informative talk. And I would like to thank our excellent moderator, Dr. Ranu Jain, and Dr. Kirti Patel for that very wonderful panel, and our expert, Dr. Ramaraju, and our eminent panelists, Dr. Ashita, Dr. Sneha, Dr. Shruti, and Dr. Meghna. And I would also like to thank our dear delegates for joining us in large numbers, and Sahiti and Shripriya for the technical support. Thank you, everyone, once again.
Thank you. Thank
Thank
you.
you, Madhumita and Radhika. Good night to all. We have more than 120 registration. Thank you.
Oh,
Yes.
Thank you, ma'am.
Thank you,
Thank you so
Dr.
much.
Deepti ma'am, for excellent presentation. And my 4 panelists, it is all your credit. You have done wonderful job. Thank you,
Thank you so
Shruti,
much, ma'am.
Meghna, Ashita. Thank you all. Thank you,
Thank you,
madam, once
respected
again.
seniors, for such a
And I
great
welcome all
opportunity.
of you to our Sanskardhani Jabalpur. Visit Ma Narmada, and we'll be very happy, all of us from Jabalpur OBGY Society, to host you, ma'am. Welcome. We are
sure,
with
sure, madam.
warm hearts. We are welcoming you all to our Jabalpur.
Sure. Done.
Thank you. Thank you for your invitation. Sometimes we'll definitely.
Akiti and Priya, good night.
Thank you.
Thank
Good night.
you.
Night all.
Thank you. Thank you so much.
Thank you,
Thank
Sambat ma'am.
Thank you. Thank you.
Thank you so much.
Thank you.
Thank you. Deepti and Rakhi.